From cells to symptoms, the pathophysiology of lung cancer. When breath becomes a battle, the case of Mr. Smith. Mr. Smith, a once adventurous 62-year-old, began smoking cigarettes in high school with his close-knit group of friends. What started as a social activity quickly turned into a lifelong addiction. With Mr. Smith smoking several packs a day, he later chose a physically demanding career in mining, which exposed him to hazardous conditions, including asbestos, contributing to his health decline. After years of struggle, he was diagnosed with chronic obstructive pulmonary disease, forcing him into early retirement. However, years of smoking and exposure to harmful substances has already taken their toll. 3 years later, he received the devastating diagnosis of small cell lung cancer, a reality that struck hard, marking a battle against one of the deadliest cancers in Canada. His once promising future now felt overshadowed by this life altering news.
Pathophysiology. Lung cancer is characterized by the uncontrolled proliferation of malignant cells within the lungs. These cancerous cells fail to differentiate into functional lung tissue, form tumors, and disrupt normal pulmonary function. There are two major types of lung cancer: non small cell lung cancer, which accounts for 84% of lung cancers, and small cell lung cancer, a more aggressive form that accounts for 13% of lung cancers. The underlying pathophysiology depends upon the category one's diagnosis falls into. In Mr. Smith's case, it would be the latter. Small cell lung cancer. Small cell carcinomas are a biologically aggressive form of lung cancer. They are distinguished by their alarming rate of growth and proliferation, allowing for easy invasion of nearby tissue structures and early metastasis. The tumors often originate from the tracheobronchial tree in the central part of the lungs and metastasize throughout the body. Small cell lung cancer is strongly linked to tobacco carcinogens, hence, they are primarily seen in smokers. Pathophysiological changes. Cellular level. Small cell carcinoma commonly begins with the initial genetic mutation of tumor suppressor cells TP53 and RB1 in response to carcinogenic exposure, such as asbestos or tobacco. This inhibits apoptosis, promoting malignant tissue survival, rapid proliferation, and accelerated tumor growth. Tissue level. Vascular endothelial growth factor is overexpressed in SCLC. Angiogenesis provides a constant supply of oxygen and nutrients to these malignant tumors, reinforcing them and encouraging their growth. As the tumors enlarge, they grow into adjacent tissues, replace healthy lung tissue, cause necrosis, and disrupt normal tissue function. Organ level. The effects of small cell lung cancer on the lungs can lead to fluid accumulation within the pleural cavity, a condition known as pleural effusion, which may result in lung collapse. The accumulation of fluid impairs lung function and causes a ventilation perfusion mismatch, thereby decreasing the efficiency of gas exchange. Additionally, the invasive characteristics of small cell lung cancer enable these tumors to rapidly exploit the lung's rich vascular supply, utilizing nutrients to support further growth, leading to bronchial obstruction and disruption of normal pulmonary function. Systemic level. The metastasis of these malignant tumors can result in debilitating systemic effects. They metastasize aggressively and form secondary tumors in the brain, liver, and bone. Additionally, patients may experience generalized fatigue, anorexia, and immunosuppression. This can be exacerbated by decreased appetite due to generalized pain and increased respiratory effort required in daily activities. The secretion of hormones by these tumors can also lead to paraneoplastic syndrome, which initiates the development of new diseases such as SIADH and ectopic Cushing syndrome.
Lung cancer by the numbers, an epidemiological overview. Globally, lung cancer has been the most common diagnosed cancer for the last several decades. Lung cancer is projected to remain the most diagnosed cancer in Canada, with 32,100 new cases expected in 2024. About 1 in 4 cancer deaths among Canadians is due to lung cancer, making it the leading cause of cancer death in this country. The lifetime probability of developing lung cancer is 7.1%. Lung cancer is the most commonly diagnosed cancer in 70 to 84-year-olds and the second most commonly diagnosed in those 85 years old and older. 98% of lung cancer diagnoses are expected to occur in people 50 years of age or older. While the number of cancer cases in 2024 is projected to increase compared to previous years, the overall rates of cancer incidence and mortality are still decreasing. This trend is likely a result of ongoing initiatives in cancer control and advancements in prevention, screening, and treatment, especially for specific cancers that have received targeted attention. The domino trail, unraveling lung cancer risks. Lung cancer risk factors. Understanding the risk factors associated with lung cancer is crucial for comprehending its development and progression. Recognizing these risk factors in patients who may be predisposed to lung cancer involves examining three key categories: modifiable, non modifiable, and environmental factors. This knowledge allows healthcare professionals to better identify at risk individuals and implement appropriate preventative measures. Tobacco smoking remains the leading risk factor for lung cancer, with cigarettes containing over 7,000 chemicals, including 69 known carcinogens. Early initiation of smoking significantly elevates the risk of developing lung cancer, underscoring the importance of targeted prevention efforts. Occupational exposure to carcinogens is another substantial contributor to lung cancer, particularly in regions that lack adequate safety regulations. Furthermore, a history of non infectious respiratory diseases, such as chronic obstructive pulmonary disease, is closely linked to both smoking and environmental carcinogens. Additionally, lifestyle factors, including poor diet and physical inactivity, further increase lung cancer risk for both smokers and non smokers. These insights highlight the critical importance of identifying and addressing risk factors to enhance prevention and health outcomes. Inherited genetics. Research has identified genetic factors associated with susceptibility to lung cancer. Key factors include mutation in genes such as TP53, a family history of lung cancer, and ethnic variations. Age. Lung cancer incidence is higher in individuals aged 40 to 75, particularly among those with a long history of cigarette smoking, peaking between ages 55 and 65. Sex. Recent studies indicate that lung cancer incidence is 20%, 27% higher in males than females, largely due to differences in smoking patterns between genders. Mr. Smith under the microscope: risk factors in lung cancer. In this section, we will be looking at Mr. Smith's specific risk factors. Mr. Smith is 62 years old, which places him at the peak age for lung cancer incidence, which is between 55 and 65. He is also a male, and males have a higher incidence of lung cancer compared to women. He has a health history of COPD and obstructive lung disease, which further exacerbates his condition. His occupation as a coal miner leads him to asbestos exposure, and lifestyle. He is a chronic smoker, which is the leading cause of lung cancer.
Mr. Smith's manifestations. Given that Mr. Smith suffers from COPD, it is not uncommon for him to exhibit symptoms of chest pain, persistent coughing, dyspnea, fatigue, and an increase in respiratory effort. However, while his symptoms are associated with his COPD diagnosis, they can also be persistent with his recent cancer diagnosis and should be monitored for an increase in severity and frequency. His malignancy may be indicated by symptoms such as blood-tinged sputum and appetite loss resulting in malnutrition. Regarding his risk factors, Mr. Smith has COPD as well as a chronic smoker who could smoke up to several packs a day. These specific risk factors for our client could result in all of the listed symptoms above. These symptoms might be a heightened version of his smoking-induced COPD, but they could also be a sign of cancer. Mr. Smith may not have identified these manifestations as cancer warning signs and may have believed they were brought on by his smoking and COPD, because these symptoms are interchangeable with his diagnosis of COPD and cancer. Hence, why this cancer is typically categorized as lethal, given that manifestations are frequently ignored until it is too late. Additional manifestations that are associated with this type of cancer can be categorized into respiratory symptoms, systemic symptoms, as well as localized symptoms, which typically occur as the cancer has advanced. So, regarding respiratory symptoms, we have a constant cough that won't go away, frequent respiratory infections, blood-tinged sputum, and chest pain and wheezing. Regarding systemic systems, we have fatigue, unexplained weight loss, and a lack of appetite, which can also be related to mucositis. As when a client has mucositis, the mucous membranes typically becomes inflamed, and that can make it not only difficult but painful for the client to eat. Therefore, they will have a lack of appetite, which can then lead to malnutrition, and then again the unexplained weight loss. Regarding localized symptoms, we can have bone pain. Bone pain is often a sign that the cancer has metastasized. We have voice hoarseness. This is due to an increase in tumor growth, which can suppress our larynx, otherwise known as our voice box, and we can have facial swelling. This is caused if the tumor grows big enough to the point where it can suppress the heart, as we know that the lungs and heart are closely related. If that occurs, we can have an obstruction, which can lead to fluid retention and thus the swelling. It's important to note that some of these symptoms that are listed here are similar to heart failure symptoms or symptoms of common respiratory infections. This is why the appropriate diagnostic testing is crucial in order to determine if, in fact, lung cancer is present. And again, remember, the earlier the catch, the better the prognosis.
Diagnostics.
Lung cancer is a common site for primary and secondary cancers. It's rarely benign tumors. The survival rate depends on the stage and when it was diagnosed. Higher survival rates when the diagnosis is early. Screening for high-risk populations is very important, especially when it comes to non-small cell lung cancers. Unfortunately, the best way to identify lung cancer is through biopsy. Lung cancer cannot be unfortunately identified through blood tests. There are, however, proto-oncogenes that are amplified through small cell lung cancer, such as the CMYC, the PDL1, which is the programmed death ligand of cancer cells, EGFR, which is a protein that is on the surface of non-small cell cancers, lung cancers, and there are paraneoplastic syndromes that come with lung cancer, such as SIADH or other neurological paraneoplastic syndromes, such as Lambert-Eaton myostatic syndrome. Sputum cytology is a non-invasive form of investigating for lung cancer, which requires the patient to cough onto a plate. Unfortunately, it's not the most effective in detecting small androcarcinomas, which is a type of small lung cancer which spreads quite quickly and is dangerous. Radiology is usually the first step to testing for lung cancer, so X-raying and CT scans or contrast CT is used in order to see an image of the lungs. However, they're not always very clear, even with the contrast CT. And the other barrier is that they can be quite expensive and long waits. The secondary stage of post-radiology of diagnosing lung cancer and the gold standard is an invasive procedure. It is usually bronchoscopy with biopsy, which requires the doctor to insert a camera into the windpipes all the way through the airways and into the lungs. A small portion of the tumor is taken to be investigated under a microscope and diagnosed. Biopsies can also be done through surgical methods such as thoracotomy or thoracoscopy, which the surgeon makes cuts into the lung tissue and between the rib cage in order to take a small piece of biopsy and diagnose the tissue in the lab. Mr. Smith's abnormal laboratory and diagnosis result were done, and due to his occupation and lifestyle, he was a candidate for high-risk populations. His doctor noticed white patches on the X-ray in the peripheral areas of the lungs. For a better image, the doctor ordered a CT scan, which identified small tumors peripheral on the left lung. In order to identify, diagnose, and stage Mr. Smith's doctor ordered a bronchoscopy with biopsy. The biopsy showed abnormal dysplasia tumors with EGFR epidermal growth factor receptors, indicating non-small cell lung cancer. Mr. Smith's blood work also showed low blood counts and low blood platelets, which suggested anemia due to the lung cancer.
Patient perspectives: living with prognosis.
70% of small cell lung cancer patients present with metastasis at diagnosis, ensuing a poor prognosis. Without treatment, small cell carcinoma is fatal, and patients rarely survive more than a few months. With treatment, patients die within 2 years. Less than 15% of localized small cell lung cancer patients are alive at the 5-year mark, and less than 2% of metastasized small cell lung cancer patients are alive at the 5-year mark. COPD is also significantly associated with a decreased chance of partial remission in lung cancer patients. The likelihood of recovery from lung cancer is generally low, but a diagnosis of small cell lung cancer and COPD presents a more grim prognosis for Mr. Smith.
So management for this client should be individualized. In the case of Mr. Smith, a personalized care plan should be implemented in order to help him cope with his diagnosis, improve his quality of life, and overall lengthen a prognosis after his diagnosis. So, in the next slide, we will talk about what Mr. Smith's plan of care might include. So, the first thing that should be included in Mr. Smith's care plan would be complete smoking cessation, as it is known that he is a chronic smoker. It is critical to his diagnosis to quit smoking, as smoking will not only exaggerate his COPD symptoms, but will also reduce the effectiveness of cancer treatments and may even remove him from the list of candidates for surgery. Furthermore, if Mr. Smith continues to smoke, he increases his risk of chronic carcinogen exposure, which would completely render him weak as well as affect his tolerance for cancer treatment. Mr. Smith should be assessed for compliance and commitment to complete cessation, which would then allow for resources to be provided to our client based on his willingness and commitment to quit smoking. Resources could include meeting with a social worker in collaboration with his physicians and nurses to develop realistic goals in order to completely quit, as well as outpatient support groups to help with smoking cessation, as well as to help with coping with his cancer diagnosis, can be introduced as well. In terms of other treatments, Mr. Smith can complete chemotherapy as well as radiation treatments. So, chemotherapy provides a systemic treatment for our client's diagnosis. It is typically used in preventing the spread. So, this may be utilized as one of his first lines of therapy, but it is typically not used alone. It would be used alongside immunotherapy as well as radiation treatment. In regarding to radiation treatment, typically radiation would be used on our client to provide a local effect. It would be used to decrease Mr. Smith's tumor size. Radiation is best used in preparation for surgery, assuming our client ever reaches that stage. So, if Mr. Smith were to need to undergo surgery to remove the tumor or remove maybe parts to where it has spread, radiation treatment would be involved to shrink the tumor size prior to undergoing surgery. Lastly, medications and pharmacology is utilized for our client. Pharmacological medications can be used to manage Mr. Smith's COPD, given that his recent cancer diagnosis may impair normal lung and airway function, which would then further exacerbate his COPD symptoms. So, medications may include bronchodilators. For example, we have albuterol, which is used to open up the client's airway. Inhaled corticosteroids, which would be used to reduce the inflammation, and oxygen administration therapy if needed to prevent hypoxia.